Some is funded by research grants, so some of my CIHR, Institute for Health Research grants, are to POGO, via POGO. And the final component is philanthropy. We work with the public sector to bring in funds to fund those things that do not belong with the government, that belong in the private sector. There is a medical director who holds an endowed academic chair that is based at a university. That person happens to be me. I am cross-appointed at several hospitals. I am cross-appointed at several universities, but I work primarily for POGO. That's who pays me. There's a full-time executive director, and that's the how-to person. In the interests of openness, the executive director happens to be my wife. We have a board that represents the senior staff of all of the hospitals and all of the disciplines. So the directors of each oncology unit, nursing, social work, psychology, pharmacy. So there is a big professional component on the board. And they are charged by law. The law says if you are a member of the board of an institution, you have to have the aims and objects of that institution as your prime function when you are doing the business of that organization. So we have a hat stand at the front door of the office of POGO. And we say to people, take off the hat you wear in the institution you work in and hang it here. Here you are working for the province. And we have some external board members that are experts in finance, governance, human resource, and health policy. So we mix the what to and the how to. What are our goals? Well, we are to coordinate and improve the childhood cancer system, to advise on childhood cancer policy, to select, standardize, collect, and analyze provincial data, to support policy and service plan, and to ensure strategic and equitable allocation of health care resources. We are required to identify growth areas and gaps, and we're required to do them in advance. So right now, for example, the whole issue of MRD, minimal residual disease, is becoming very important. How are we going to do this? We're going to set up 7 labs in the province to do MRD. The answer is no. We are going to create a system that has a centralized lab, but that has some guarantees that the other institutions will tell us. Give us a 24-hour turnaround. Give us service 7 days a week. Give us electronic reporting. And the government understands that this is in fact a significant saving. So what does that translate to? It translates to the fact that in a fashion not different to what you are doing, and again I congratulate you for where you are, POGO sits at the interface of the hospitals, the universities, the partners like the Canadian Cancer Society and the research institutions, the childhood cancer community, parents, survivors who have been there and done that, government and the private sector, and all of them put their hats on the hat stand when they come to talk about childhood cancer. So the umbrella has been created. We have an integrated system of care that all of the hospitals belong to. It is a tertiary and quaternary network with a satellite network, so some components of care that are the easier components can be delivered close to home. We have a nursing service that moves, or internet that moves between hospital and home. So in the early part when the child is newly diagnosed, these nurses go into the home and help the parents set up their lives. If the child does well, they don't reappear, but if the the child does not do well, if they need end-of-life care, this group comes in again. We have survivor clinics that are linked to all of these institutional bases. We have created some advantages for parents and families, like financial assistance, so that these kids will be independent as they grow up. This is not a government responsibility, this is a philanthropic responsibility, and so the funds go there. And we've created a mechanism for evaluation and research that is above institutions. We have a database, and I'll tell you more about it in a moment. We have a little research unit, and we produce annual reports to tell the decision makers what's happening, what are we doing, and how is it moving forward. We have produced recommendations that have been implemented for how you create a team that works. This has been developed via literature review, by Delphi panel, and by experimentation. We have said for every 15 new cancers, one pediatric oncologist should have 15 new cases per year, because that translates to 60 cases of active cancer. One case coordinator per 15, one data manager per 25, one social worker per 25, so that there's a structure, there is a team that is funded, and you don't have to beg for these resources. What I haven't shown you here is we have also said how many diagnostic imaging people, how many pathologists to operate a freestanding cancer center. And all of this is based on a data system, which is called POGO, which stands for the Pediatric Oncology Group Network Information System. And it has a demographic component. It has information about the diseases classified by the ICCC, the International Classification of Childhood Cancer. It has information on all treatments, death, late effects, and health service utilization. So what does that mean? We can do surveillance activity. We can look at the population profile, service delivery, demand and volume, incidence trends, treatment trends, and system performance measurements. So, for example, this is the age-adjusted incident rate per 100,000 of childhood cancer in the whole province. This happens to be 85 to 2004, and we can tell you it's not really changing. It's wobbling a little bit around the baseline, but it isn't changing, and that's population-based. This is the similar data for leukemia in the province of Ontario, and we know we have 100% capture. Every kid in the province is on that graph. We can do it geographically, and I don't know if that's happening in Brazil, but we keep being asked, are there clusters, are there concentrations of cancer? And we can answer those questions by using this technology, spatial map planning. This happens to be for all cancers, and the color tells you the number of cases adjusted to the million population of age. This is all cancers. We can do it by disease. This happens to be leukemia. And right now there's an interesting thing happening there. This is fairly long-standing data. There may be a cluster happening over there, so the epidemiology group are moving in to see if there's anything real there. We can talk about service volumes and cases. This looks at a 5-year average annual caseload, new cases, so this is over 5 years. Ongoing active treatment, long-term follow-up, total caseload. We can do it by year, so there's a trending rather than an averaging. This is active treatment and active follow-up. This is defined as the on treatment and first 2 years over. After treatment, same ability to report on these, and this has implications for how many doctors, how many nurses, how many pharmacists, and it has implications for being sure everybody is equitable. We do not have one center with doctors and no nurses, or one center without the ability to do CT scans or whatever it is.